The journey of aging is often romantically depicted as a descent into a golden twilight, a time of rest and reflection after decades of labor. Yet for millions of elderly individuals across the globe, this period is marred by an unwelcome and persistent companion known as chronic pain. As the biological machinery of the human body endures the wear and tear of time, the joints that once moved with fluid grace begin to grind, the cartilage thins, and the skeletal structure succumbs to the inflammatory processes of osteoarthritis and rheumatoid conditions, creating a daily reality where mobility is purchased at the price of suffering. In this landscape of constant discomfort, pain relief medication appears not merely as a pharmaceutical intervention, but as a lifeline, a necessary tool to maintain a semblance of independence and dignity in daily living. However, this reliance on pharmacological solutions, specifically nonsteroidal anti-inflammatory drugs, NSAIDs, and corticosteroids, has silently metamorphosed into a pervasive public health crisis, characterized by a dangerous drift from therapeutic use to habitual abuse, a phenomenon that is wreaking havoc on the physiology of the elderly in ways that are often invisible until catastrophic failure occurs. To understand the gravity of abusing bone and joint pain medication, one must first dismantle the mechanism of pain itself and the seductive, almost miraculous nature of the drugs designed to silence it, for it is in this biological interaction that the seeds of destruction are sown. When an elderly person swallows a pill, be it ibuprofen, diclofenac, or a more potent corticosteroid, they're initiating a complex biochemical cascade designed to interrupt the body's natural alarm system. Pain, fundamentally, is a protective signal mediated by the release of signaling molecules called prostaglandins, which are produced by enzymes known as cyclooxygenases, or COX enzymes, at the site of tissue injury or inflammation. These prostaglandins cause the blood vessels to dilate, leading to swelling, redness, and the sensitization of nerve endings, which the brain interprets as pain. The mechanism of most common joint pain medications is to inhibit these COX enzymes, effectively shutting down the production of prostaglandins and thereby muting the signals sent to the brain. In the short term, this pharmacological blockade feels like a restoration of youth. The stiffness dissipates, the gnawing ache subsides, and the user feels a renewed capacity for movement. It is precisely this immediate efficacy that fosters the initial stage of abuse, not necessarily driven by an intent to get high in the recreational sense, but driven by a desperate desire to escape the prison of immobility. However, the tragedy lies in the fact that the body's physiological processes are not isolated switches that can be flipped without consequence. Biology is a web of interconnected systems, and the enzymes that regulate pain are the very same enzymes responsible for maintaining critical homeostatic functions within the body. The first and perhaps most historically documented casualty of this pharmacological warfare is the gastrointestinal tract, a system that becomes increasingly vulnerable as the human body ages. The COX-1 enzyme, which is indiscriminately blocked by many traditional NSAIDs along with the inflammation-causing COX-2, plays a vital housekeeping role in the stomach and intestines. Its primary function is to stimulate the production of a protective mucus layer that coats the inner lining of the stomach, shielding the delicate mucosal tissue from the harsh, acidic environment necessary for digestion. When an elderly individual, whose stomach lining may already be thinned due to age-related atrophy, begins to consume painkillers chronically or in doses exceeding the recommended limits, they are effectively stripping away this protective chemical shield. Without the prostaglandin-mediated defense, the gastric acid begins to digest the stomach's own lining, initiating a process of erosion that is insidious because it is often entirely asymptomatic in its early stages. Unlike a skin wound that is visible and painful, damage to the gastric mucosa can proceed silently, masking its severity with the very analgesic properties of the drug causing the injury, creating a paradox where the patient feels less joint pain while their internal organs are subjected to chemical burns. This silent erosion creates a dangerous clinical blind spot for both patients and healthcare providers, as the classic warning signs of gastrointestinal distress, such as heartburn or indigestion, may be absent in older adults due to altered pain perception or the masking effects of the medication itself. Consequently, the abuse of painkillers often continues unchecked until the damage penetrates the deeper layers of the gastric wall, leading to the formation of peptic ulcers. In the elderly demographic, the risk of these ulcers bleeding is significantly amplified, not only because of the medication, but also due to the frequent concurrent use of anticoagulants or blood thinners like aspirin or warfarin prescribed for cardiovascular protection. When these factors converge, the result is often a sudden, life-threatening gastrointestinal hemorrhage. The clinical presentation is stark and terrifying. A patient may feel fine one moment, and the next be vomiting blood or passing black, tarry stools, signaling massive internal bleeding. The physiological reserve of an older adult is significantly lower than that of a younger person, meaning they're less able to compensate for rapid blood loss, leading to a higher mortality rate from what essentially began as a routine attempt to manage knee or back pain. The abuse of these medications transforms the stomach from a digestive organ into a ticking time bomb, where the integrity of the mucosal barrier is compromised daily, turning the simple act of taking a pill into a game of physiological Russian roulette. Furthermore, the damage is not confined to the stomach alone. The toxicity of NSAID abuse extends downstream to the small intestine and colon, causing a condition known as NSAID enteropathy. This condition is characterized by increased permeability of the intestinal wall, often referred to as leaky gut, where the tight junctions between intestinal cells break down, allowing bacteria and toxins to translocate from the gut into the bloodstream. This translocation triggers a systemic low-grade inflammation, which ironically exacerbates the very joint pain the patient is trying to treat, creating a vicious feedback loop. The patient perceives an increase in pain, attributes it to a worsening of their arthritis, and responds by increasing the dosage of their medication, thereby accelerating the intestinal damage. This cycle of destruction is compounded by the fact that elderly individuals often suffer from polypharmacy, taking multiple medications for hypertension, diabetes, and cholesterol. The chemical interactions between painkillers and these other drugs can alter gastrointestinal motility and blood flow, leading to strictures, perforations, and obstructions in the lower bowel. Beyond the direct chemical injury to the gut lining, we must also consider the systemic impact of corticosteroid abuse, often taken as oral prednisone or frequent intraarticular injections when NSAIDs no longer suffice. Steroids are potent anti-inflammatory agents that work by mimicking the effects of cortisol, the body's primary stress hormone. While they are powerfully effective at reducing joint inflammation, their chronic use wreaks havoc on the gastrointestinal tract in a different, but equally destructive manner. Corticosteroids suppress the immune system and inhibit the reparative processes of tissues. When taken in conjunction with NSAIDs, a common practice among chronic pain sufferers desperate for relief, the risk of gastrointestinal bleeding increases by more than tenfold. The steroid prevents the healing of the microerosions caused by the NSAID, while simultaneously masking the symptoms of peritonitis should a perforation occur. This means an elderly patient could suffer a rupture in their intestine and not present with the classic rigid abdomen or severe pain until sepsis is set in. The narrative is further complicated by the misconception that over-the-counter availability equates to safety. Many elderly patients operate under the false assumption that because a drug like naproxen or ibuprofen can be purchased without a prescription, it is inherently benign. This psychological safety net encourages self-medication and dosage escalation without medical oversight. Therefore, the first chapter in the tragic story of analgesic abuse is written in the lining of the stomach and intestines. It is a story of a protective barrier destroyed by the very remedy intended to heal. As the gut fails, the nutritional status of the senior declines, their resilience to infection drops, and their overall frailty increases, setting the stage for the systemic failures that affect other organs. While the erosion of the gastrointestinal tract presents a visceral and often bloody warning sign of analgesic abuse, there exists a far more insidious and potentially lethal threat lurking within the circulatory system. A threat that strikes without the premonitory pains of an ulcer, but with the devastating suddenness of a thunderclap. As we delve deeper into the systemic ravages of chronic painkiller misuse in the elderly, we must confront the uncomfortable reality that the very mechanisms designed to reduce inflammation in the joints are simultaneously waging war on the heart and blood vessels. This cardiovascular siege begins with a subtle disruption in the delicate biochemical balance that maintains vascular health. Under normal physiological conditions, the body maintains a precise equilibrium between prostacyclin, a molecule that promotes the dilation of blood vessels and inhibits platelet aggregation, and thromboxane, which encourages clotting and vessel constriction. This balance is the linchpin of cardiovascular stability, ensuring that blood flows freely while retaining the ability to clot when necessary to prevent hemorrhage. However, the introduction of COX-2 inhibitors, a class of NSAIDs specifically developed to spare the stomach from the damage described previously, inadvertently disrupts this harmony. By selectively suppressing prostacyclin while leaving thromboxane largely unchecked, these drugs tip the scales toward a prothrombotic state. For an elderly individual whose blood vessels are already stiffened by atherosclerosis and whose heart may be burdened by decades of pumping against resistance, this chemical shift creates the perfect storm for catastrophe. The abuse of these medications essentially thickens the blood and narrows the pathways through which it must travel, forcing the heart to work harder against increased resistance. This phenomenon is clinically manifested as a creeping elevation in blood pressure, a side effect that is frequently overlooked or misattributed to the natural progression of aging. An elderly patient, perhaps already managing hypertension with a delicate regimen of medications, may find their blood pressure spiraling out of control despite adherence to their antihypertensive therapy, unaware that the ibuprofen or celecoxib they consume daily for knee pain is directly antagonizing the effects of their heart medication. The consequences of this uncontrolled hypertension are cumulative and severe, accelerating the wear on the arterial walls and increasing the workload on the left ventricle of the heart. Over time, this leads to hypertrophy, a thickening of the heart muscle that paradoxically weakens its pumping efficiency, laying the groundwork for heart failure. The tragedy is that the symptoms of worsening heart failure, shortness of breath, fatigue, and swelling in the extremities, can easily be dismissed as mere signs of getting old, allowing the pathology to advance to a critical point where recovery is no longer possible. Furthermore, the fluid retention caused by NSAIDs acts as a force multiplier for cardiovascular stress. These drugs interfere with the kidney's ability to excrete sodium, leading to an accumulation of salt and water in the body. For a healthy young person, this might result in minor bloating, but for an elderly heart that is operating on the edge of its functional reserve, this extra fluid volume acts as a suffocating burden. It stretches the heart chambers, exacerbates valve regurgitation, and can precipitate acute decompensated heart failure, sending the patient to the emergency room gasping for air as their lungs fill with fluid. This state of volume overload is a direct physiological consequence of the drug's interference with renal prostaglandins, which brings us to the next theater of destruction, the kidneys. The kidneys are not merely filters. They are sophisticated organs that regulate blood pressure, electrolyte balance, and red blood cell production, all of which are critically dependent on adequate blood flow. In the aging body, the kidneys are often already in a state of reduced function, a condition known as senescent nephrosclerosis, with a number of functioning filtering units, or nephrons, has naturally declined. To maintain filtration in this compromised state, the aging kidney relies heavily on the vasodilatory effects of prostaglandins to keep the afferent arterioles, the tiny vessels feeding blood into the filters, wide open. When an elderly person abuses painkillers, they are effectively chemically clamping these vital arteries shut. The abrupt reduction in blood flow induces a state of renal ischemia, starving the nephrons of oxygen and nutrients. This can lead to acute kidney injury, AKI, a sudden and rapid loss of kidney function that can occur within days of starting high-dose analgesic therapy. However, More common, and perhaps more dangerous in the long term, is the slow, silent progression of chronic kidney disease, CKD. This form of damage is relentless and often asymptomatic until the kidneys have lost more than nearly all of their function. The patient may continue to take their pain pills, oblivious to the fact that their creatinine levels are rising and their glomerular filtration rate is plummeting. By the time symptoms such as nausea, confusion, and reduced urine output appear, the damage is often irreversible, condemning the patient to a future of dialysis, a grueling treatment regimen that significantly diminishes quality of life and life expectancy. The condition known as analgesic nephropathy is a testament to this destruction, characterized by the actual death of the renal papillae, the structures where urine flows into the bladder. It is a form of tissue necrosis induced entirely by the consumption of drugs meant to improve the quality of life, a cruel irony that underscores the toxicity of these substances when used without restraint. The danger is amplified exponentially when we consider the hepatic system, or the liver, particularly in the context of paracetamol, acetaminophen abuse. While NSAIDs attack the gut and kidneys, paracetamol targets the liver. Often perceived as the safest painkiller, this perception fuels a casual attitude towards dosage that can be fatal for the elderly. The aging liver shrinks in volume and blood flow, and the enzymatic pathways responsible for metabolizing drugs become less efficient. Specifically, the levels of glutathione, a molecule essential for neutralizing the toxic byproducts of paracetamol metabolism, are often depleted in older adults due to poor nutrition or chronic illness. When an elderly person, frustrated by the lack of relief from standard doses, decides to double up on their medication or combine prescription opioids containing acetaminophen with over-the-counter cold remedies, they can inadvertently cross the threshold of toxicity. Unlike the immediate pain of a stomach ulcer, liver toxicity is a silent assassin that manifests days after the overdose. The patient may feel a vague malaise or nausea, symptoms easily ignored, while the liver cells are undergoing massive necrosis. By the time jaundice appears, the yellowing of the skin and eyes, the liver may have already entered fulminant failure, a catastrophic event that leads to encephalopathy, coma, and death. The margin for error in the elderly is razor thin. A dose that is safe for a 30-year-old can precipitate liver failure in an 80-year-old, especially if alcohol consumption is also a factor. However, the most complex and prevalent danger in the elderly population arises not from the toxicity of a single drug, but from the chaotic interplay of multiple medications, a phenomenon known as polypharmacy. The elderly are the largest consumers of pharmaceuticals, often juggling prescriptions for diabetes, hypertension, cholesterol, and blood thinning. Into this delicate chemical ecosystem, the introduction of high-dose painkillers acts as a destabilizing agent, triggering a cascade of drug-drug interactions that can be lethal. One of the most notorious and dangerous interactions is the triple whammy, a colloquialism used in geriatric medicine to describe the concurrent use of an ACE inhibitor for blood pressure, a diuretic, water pill, and an NSAID. This combination is a recipe for renal failure. The diuretic reduces plasma volume. The ACE inhibitor dilates the efferent arteriole, reducing glomerular pressure, and the NSAID constricts the afferent arteriole, cutting off blood supply. Together, they effectively shut down the kidney's filtration pressure from all sides, leading to a precipitous drop in function. This interaction is entirely predictable and preventable, yet it occurs with alarming frequency because patients often self-medicate with OTC painkillers without consulting their physicians, or because different specialists prescribing different drugs fail to communicate. Moreover, the interaction between painkillers and anticoagulants like warfarin or the newer direct oral anticoagulants is a game of high stakes. NSAIDs not only damage the stomach lining, but also impair platelet function. When added to a blood thinner, the risk of spontaneous hemorrhage skyrockets. We are not just talking about gastrointestinal bleeding, but also intracranial hemorrhage, bleeding in the brain. An elderly person on blood thinners who takes NSAIDs for arthritis and then suffers a minor fall is at a significantly higher risk of developing a subdural hematoma, a bleed that compresses the brain and can lead to permanent disability or death. The painkiller weakens the body's primary hemostatic defense, while the anticoagulant inhibits the secondary defense, leaving the patient defenseless against their own vasculature. Similarly, the interaction with corticosteroids creates a synergistic toxicity. As mentioned regarding the gut, the combination destroys the mucosal barrier. But systematically, steroids also cause fluid retention and elevate blood pressure and blood sugar, compounding the cardiovascular and metabolic risks posed by NSAIDs. The result is a metabolic disarray where the patient's diabetes becomes unmanageable, their blood pressure erratic, and their heart failure prone to decompensation, all driven by the pursuit of pain relief. We must also consider the electrolyte disturbances that these medications provoke. The elderly homeostatic mechanism is less robust in handling shifts in potassium and sodium. NSAIDs suppress the production of renin and aldosterone, hormones critical for potassium excretion. This can lead to hyperkalemia, a dangerous elevation of potassium levels in the blood. Hyperkalemia is silent but deadly. It does not cause pain, but it destabilizes the electrical rhythm of the heart, potentially leading to sudden cardiac arrest. An elderly patient taking potassium-sparing diuretics for heart failure, who adds ibuprofen to their regimen, is unknowingly walking a tightrope. The fatigue and weakness they feel may not be age-related frailty, but the early signs of a toxic electrolyte imbalance that could stop their heart at any moment. This is the insidious nature of analgesic abuse. It mimics the symptoms of aging while actively accelerating the dying process. Thus, the cardiovascular and renal systems, the engines of life, are placed under siege. The heart pumps against a hardened, constricted vascular tree, struggling with fluid overload. While the kidneys are slowly strangled by ischemia, their ability to filter toxins waning day by day. The liver, the body's chemical factory, is pushed to its metabolic limits, risking collapse from toxic accumulation. This multi-organ assault is rarely the result of a single massive overdose, but rather the accumulation of daily micro-insults from chronic use. The elderly patient does not see the rising creatinine, the thickening heart muscle, or the microscopic liver damage. They only feel the relief in their knees. This disconnect between the subjective sensation of relief and the objective reality of physiological destruction is what makes the abuse of pain medication so dangerous. It is a trade-off where the short-term gain of mobility is paid for with the long-term capital of organ reserve. Having traversed the hidden landscapes of the gastrointestinal, cardiovascular, and renal systems, witnessing the havoc wrought by the unchecked chemical warfare of analgesic abuse, we must now turn our gaze to the very structures these drugs are purportedly intended to save: the skeleton and the joints. It is here, in the architectural framework of the body, that the most cruel and ironic chapter of this crisis unfolds, a phenomenon we might call the skeletal paradox. The prevailing logic among patients is simple and linear. If the joint hurts, the medicine stops the pain, and therefore, the medicine is good for the joint. However, biological reality is far more convoluted. Pain, in the context of osteoarthritis and degenerative joint disease, serves a critical evolutionary function. It is a biological brake, a governor that limits motion to prevent further damage to eroding cartilage and stress subchondral bone. When an elderly individual suppresses this signal completely with high-dose painkillers, they effectively sever the line of communication between the injured tissue and the brain. The result is that they continue to load and grind a damaged joint with a force it can no longer withstand. This is akin to a runner numbing a fractured ankle to finish a race. They may cross the finish line, but the ankle will be shattered beyond repair. In the orthopedic world, this is sometimes referred to as analgesic arthropathy, a condition where the rapid destruction of the joint is accelerated precisely because the protective limitation of pain has been chemically removed. The patient feels a false sense of liberation, engaging in activities that grind the remaining cartilage into dust, leading to a precipitous decline that necessitates total joint replacement much sooner than if the pain had been managed more conservatively. The destruction extends beyond the joint surface to the very density of the bone itself, particularly when corticosteroids are part of the abuse regimen. Steroids are catabolic agents. They break down tissue. In the context of bone metabolism, they're disastrously efficient at tipping the balance between osteoblasts, the cells that build bone, and osteoclasts, the cells that resorb it. Chronic steroid use suppresses the builders and emboldens the destroyers, leading to a rapid demineralization of the skeletal structure. For the elderly woman who is already postmenopausal and battling the natural decline of estrogen, the addition of chronic steroids acts as a turbocharger for osteoporosis. The trabecular meshwork inside the vertebrae and the femoral neck, the hip, becomes brittle and honeycombed, losing its structural integrity. This leads to a terrifyingly high incidence of vertebral compression fractures, where the spine literally collapses under the weight of the body, causing the hunched dowager's hump, loss of height, and excruciating back pain that drives the patient to seek more painkillers, creating a self-perpetuating cycle of fracture and pharmacological dependence. Furthermore, steroids impair the absorption of calcium from the gut and increase its excretion through the kidneys, chemically starving the bones of their essential building blocks. This is not a side effect. It is a guaranteed physiological outcome of long-term use, turning a sturdy skeleton into a fragile house of cards waiting for the slightest breeze to topple it. Perhaps even more devastating than the weakening of the bone is the specific condition known as avascular necrosis or osteonecrosis. This is a condition often precipitated by steroid abuse, where the blood supply to a specific section of bone, most commonly the head of the femur and the hip joint, is cut off. The bone tissue, deprived of oxygen, dies and eventually collapses. This is not a gradual wearing down like arthritis. It is a structural failure, a cave-in of the bone that causes sudden, severe, and disabling pain. It transforms a manageable condition into a surgical emergency, often requiring complex reconstruction in patients who, as we have established, are likely suffering from drug-induced kidney and heart issues that make them poor candidates for anesthesia. The irony is palpable. The drugs taken to preserve mobility end up necessitating the most invasive orthopedic interventions, often leaving the patient more immobile than when they started. The tendons and ligaments, too, are not spared. Steroids and certain NSAIDs inhibit collagen synthesis, weakening the soft tissues that stabilize the joints. This increases the risk of tendon ruptures, such as the Achilles or the rotator cuff, which in an elderly person can spell the end of independent living. Thus, the musculoskeletal system is not saved by these drugs. It is slowly dismantled by them. Beyond the physical structures, the shadow of analgesic abuse falls heavily across the mind and the nervous system. The elderly brain is chemically distinct from the young brain. It has less water content, reduced blood flow, and altered neurotransmitter levels, making it exceptionally sensitive to the psychoactive effects of medication. While NSAIDs are not typically associated with a high, they, along with opioids and muscle relaxants often prescribed in tandem, contribute to a state of chronic cognitive impairment. This is often misdiagnosed as the early onset of dementia or Alzheimer's disease. The patient becomes forgetful, confused, or experiences a brain fog that makes daily tasks difficult. This cognitive dulling leads to social withdrawal and depression, which in turn amplifies the perception of pain, causing the patient to reach for the pill bottle once again. It is a neurological trap, but the most immediate and lethal neurological consequence is the disturbance of balance and proprioception, the body's ability to sense its position in space. Many pain medications, including mild opioids like tramadol or combination drugs, cause dizziness, sedation, and orthostatic hypotension, a drop in blood pressure when standing up. For a geriatric patient, a dizzy spell is not a minor inconvenience. It is a life-threatening event. Falls are the leading cause of injury-related death in adults over 65. When we combine a drug-induced lack of balance with the drug-induced osteoporosis we just discussed, the result is a catastrophic hip fracture. The statistics are grim. A significant percentage of elderly patients who suffer a hip fracture never return to their previous level of independence, and a shocking number die within a year due to complications of immobility like pneumonia or blood clots. Therefore, when an elderly person abuses painkillers, they're not just treating a sore knee, they're significantly increasing their statistical probability of suffering a terminal fall. The medication acts as a blindfold, obscuring their sensory input and leaving them vulnerable to gravity. The sedating effects also disrupt the natural sleep-wake cycle, leading to daytime drowsiness and nighttime insomnia, which drives the use of sleeping pills, further adding to the anticholinergic burden on the brain, a cumulative chemical load that has been definitively linked to long-term cognitive decline and dementia. The attempt to numb the body thus ends up numbing the mind, stripping the individual of their sharpest asset in the fight against aging, their intellect and awareness. This brings us to the psychological dimension of the crisis, the learned helplessness and the emotional addiction to the ritual of pain relief. Chronic pain is exhausting. It erodes the spirit. The pill offers a moment of control in a life where the elderly person feels they are losing control over their body. Over time, the pill becomes a psychological crutch. The fear of pain becomes more debilitating than the pain itself, leading to anticipatory dosing, where medication is taken not because pain is present, but because the patient is terrified it might return. This behavior is reinforced by the immediate gratification the drug provides, creating a dopamine-driven feedback loop that is hard to break. The patient ceases to engage in active coping mechanisms like stretching, walking, or socializing, believing that the only solution lies in the bottle. This passivity accelerates physical deconditioning. Muscles atrophy from disuse, joints stiffen further, and the baseline level of pain actually increases due to inactivity, confirming the patient's belief that they need the drugs. Breaking this cycle requires more than just stopping the medication. It requires a fundamental shift in the patient's relationship with their own body and their understanding of pain. So, how do we navigate out of this labyrinth of toxicity? The conclusion of this analysis is not a call for the absolute prohibition of pain medication, for that would be cruel and inhumane. Pain relief is a fundamental human right. Rather, it is a call for a paradigm shift from pain elimination to function preservation and harm reduction. We must move away from the monotheistic worship of the pill and embrace a polytheistic, multimodal approach to pain management. This begins with education, unmasking the silent dangers we have explored so that patients and families understand that the safe, over-the-counter drug is a potent chemical agent with systemic consequences. It involves the rigorous monitoring of organ function, checking the creatinine, the liver enzymes, and the hemoglobin, treating these values as vital signs as important as blood pressure. It requires the courage to deprescribe, to slowly taper medications that are doing more harm than good, and to substitute them with safer alternatives. Topical NSAIDs, for instance, offer a beacon of hope. Applied directly to the knee or hand, they provide high local concentrations of the drug to the joint while barely entering the bloodstream, sparing the stomach, kidneys, and heart from the systemic assault. The use of intraarticular injections of hyaluronic acid or platelet-rich plasma, while not miracle cures, offers mechanical lubrication and biological support that does not rot the gut. But beyond pharmacology, the solution lies in the physical and the behavioral. Motion is lotion is not just a rhyme. It is physiological fact. Gentle, low-impact movement, aquatic therapy, tai chi, stationary cycling, pumps nutrient-rich synovial fluid into the cartilage and strengthens the muscles that act as shock absorbers for the joints. A strong quadriceps muscle can take a significant load off an arthritic knee, providing relief that is mechanical, sustainable, and side-effect-free. Weight management is also paramount. Every pound of body weight lost removes 4 pounds of pressure from the knees. These are the hard cures, requiring effort and discipline, unlike the easy cure of swallowing a pill. But they're the only cures that build health rather than borrow against it. Ultimately, that the tragedy of analgesic abuse in the elderly is a tragedy of short-termism. It is a frantic attempt to buy comfort today at the expense of survival tomorrow. The body is an ecosystem, a deeply interconnected web where a chemical dropped into the stomach ripples out to the heart, the kidneys, the bones, and the brain. We cannot treat the part without considering the whole. This silent crisis is silent only because we have chosen to ignore the whispers of the failing organs until they become screams. By acknowledging the full spectrum of these dangers, from the erosion of the gastric lining to the collapse of the vertebrae and the clouding of the mind, we can begin to chart a safer course. It is a path that respects the fragility of the aging body, that values function over total numbness, and that recognizes that true wellness is not found in a prescription bottle, but in a holistic balance of movement, nutrition, and mindful medical stewardship. Only then can we ensure that the golden years are not tarnished by the very chemicals meant to polish them, allowing our elders to live not just with less pain, but with more life, more dignity, and more wholeness. The conversation must change, the awareness must spread, and the abuse must end, for the cost is simply too high to pay.